Hello, and welcome to the Clinical Care Options Rheumatology Podcast. I'm your host, Nicole Rochino. Today's episode features expert discussion on key patient considerations and promising new advances for Sjogren's. Nurse practitioner Betsy Kircher and Dr. Hal Scofield also provide opportunities for multidisciplinary Sjogren's management. This episode is part of a larger educational program titled Making Progress in Sjogren's, Key Considerations for Improving Recognition, Disease Management, and the Potential of Emerging Therapies. For more information on Betsy Kircher and Dr. Hal Scofield, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Well, Betsy, what do you think are the biggest problems or impediments to telling patients about a new diagnosis of Sjogren's?
Think of it as a lot like lupus, where you're taking so many different symptoms and patient experiences and just sort of putting them under one label. But, everybody's experience is different. Whereas sometimes, not always, but sometimes with rheumatoid arthritis or GPA or something, there's a basic sort of path that you can expect patients to follow. And with Sjogren's, it could be, oh, did I not tell you about the neurological part of it? Sorry. The biggest thing is just to not overwhelm them. I think that's the biggest challenge, is just to, especially the first couple visits, everything in rheumatology is a marathon, not a sprint.
Yeah.
So just not to overwhelm them and just sort of let them, meet them where they are and say, well, what questions do you have? Like, start with that. And if they've heard something terrible, then they can get that out of their head right away. We can talk about it. What about you?
Well, almost everyone has heard of lupus when you start talking about lupus as a diagnosis, but that's almost never the experience with Sjogren's. Almost no one's ever heard of Sjogren's before.
So true.
But Sjogren's and lupus are a lot alike, kind of as you said. Paper we wrote a few years ago about the heterogeneity of the disease in lupus, but the same's true for Sjogren's. We said patients might be sitting in our waiting room and they realize that the only thing they have in common is we're calling them both lupus or Sjogren's. And that's not quite so true with Sjogren's because almost everyone's going to be dry. But maybe everything else is different about their experience with the disease and what's the matter with them, and everything about it is different. And so, yeah, you're right. It's a unique path for every patient.
And then you're speaking this other language all of a sudden, like you said.
That's right.
They've heard of lupus, they've heard of psoriasis or psoriatic arthritis, but then you start out Rho and La and SSA and Sjogren's, and they don't even know how to pronounce it,
I think patients are really surprised. I get this a lot. You say, you may have this Sjogren's. Well, I don't have any family members with this, but that's, 90% of patients don't have a family member. It is, of course, it does run in families. And if you have a primary relative, like a sister with Sjogren's, well, maybe your chances are 5% or 10%. That's, of course, way higher than the population rate, 10 or 20 times higher, but it's still not that high. And so patients are always surprised by that. These diseases run in families, but it's still not overwhelmingly that they're running in families.
And do you find that it's a very different conversation if you've already been following them for some rheumatic disease, and then they develop secondary Sjogren's?
Yeah.
Then they sort of understand the language, understand that, you're not going to get an answer today. We're not going to fix this today. Versus when they come in with, it's probably secondary, but it shows up first and they haven't shown up with their RA, that kind of thing. And then it's a totally different conversation.
Or maybe they have anti-CCP. They have Sjogren's picture, but anti-CCP. So you kind of anticipate they're going to eventually develop the rheumatoid arthritis-like picture, which seems to be the data from multiple studies these days. If you have those antibodies, it's not true for rheumatoid factor so much. That confuses patients and doctors, I think. We looked at our patients, and we run a clinic that's sort of one-stop shopping for Sjogren's. So they get evaluated by me and an ophthalmologist and a dentist all in one clinic visit. There's nothing really special about our dental office or our dental room or our eye room, except they share a wall in the same clinic. And so it kind of kills half a day, but they get to see everybody. Yeah, it's all new for people a lot of times. And I think patients are confused because our clinic is clinical care, but also research. Everybody's sent it for research. And we send them a letter eventually saying, you met the research criteria. So we have to explain to people, research criteria are really not diagnostic criteria. And they're supposed to be a high bar for research. And so you might not meet these criteria, but your doctor and we still think the best diagnosis for you is Sjogren's. That's the way it works, and that's the way it's supposed to work.
That is a huge thing.
Yeah.
Because patients Google it, which we encourage our patients to Google
and
go to a reputable site and get educated. But then they say, well, I never got that biopsy.
Right.
Like, well, trust me, you don't want it. So,
you probably don't want it.
when we get more into do you guys do the ultrasound there in your
Yes.
clinic?
Yeah, we do
Oh,
ultrasounds
see,
on everybody.
that I think is just one of the most exciting things. And I would love to be able to bring that to our clinic and tell patients, here is another piece of the puzzle that can reassure you. We looked and we see it without having to slice you open and put painful stitches in.
Yeah, I mean, the ultrasound it looks like there's a lot of people with abnormal ultrasound that don't have Sjogren's, but still, it is
But
very
if you're
useful.
leaning that way, yeah.
Yeah, we're finding it very useful, and it's not totally replacing a biopsy, but maybe it will at some point, or maybe something else will replace biopsy, largely for clinical purposes. On the other hand, if you have dry eyes and dry mouth, and maybe in some kind of abnormal ophthalmology exam, and you've got the antibodies in your blood, you've got anti-Ro and then anti-Ro SSA, well, then surely that's what you've got. Yeah, you don't need the biopsy at that point.
I know one of the topics we're going to talk about today is barriers to care for patients. And you guys sound like you've sort of taken away one of the biggest barriers, which is Sjogren's. They have to see an ophthalmologist. They have to see a dentist regularly. They have to come see us, for medication refills. They might need to be seeing hem-onc if their SPEP was abnormal, And if we want to get a lip biopsy, even though we're in a large tertiary care medical center, it's still put in the referral, call this number, 3 weeks later, take another day off work. And we still have the other barriers, but
And even if you get the biopsy, it's one of the challenges for diagnosis. You need a biopsy to make diagnosis, but then if you're trying to go to sort of random pathologist who's not interested in this problem, you may get a report back that doesn't really tell you what you and I need to know about it to say you do or don't have Sjogren's. And so you got to not only find somebody to do the biopsy, you got to find the right person to read the biopsy. And so we have an dental oral pathologist that reads our biopsies. And so that's a much better situation than just going whoever's up next, in pathology. Getting all that done. And not only do you have to see an ophthalmologist and a dentist, you've got to see an ophthalmologist and a dentist that are interested in this problem. That's hard for patients to figure out too.
Right. And then if they end up on hydroxychloroquine, then they have to see one that will do the OCT and not just say, oh, I know what I'm doing. Yeah, no. Yeah.
Yeah, you have hydroxychloroquine is probably the first thing we think about in terms of systemic illness. There are side effects, mostly in your eye, but pretty well tolerated. Those side effects are cumulative based on the total amount dose you've taken in your whole life. So even if you get that side effect, it's years away given the doses people take. But before that, we're giving people, and I'm sure you are too, we're giving people symptomatic therapy it might just be artificial tears and artificial saliva, which sometimes you got to work a little hard as a patient. You got to work a little bit to get that artificial saliva. It's maybe not just sitting on the shelf in your pharmacy. You got to ask them to order it or something. And then you have the stimulatory drugs that will stimulate your salivary gland, your lacrimal glands to make tears and saliva. But we tell all those people the same thing. Like, this makes you feel better if you like it and you're less dry and that's good for you, then keep taking it. On the other hand, if you're sweating too much and your heart's racing and it doesn't make you feel better, well, then you can stop it. This doesn't modify the disease. It's only about making you feel better.
Exactly. Yeah. That's one of the biggest sort of things I have to be careful about when I'm talking to patients. We start just like everybody, I think, and the guidelines that you start with the symptomatic stuff.
Yeah.
And it's very much like, try it, see if it works. Oh, you like this brand of gel drops at night? Great. Use those. Oh, you didn't like those? Okay. Don't use them. And a couple pearls, preservative free, all that stuff. And we have Epic where I work. And so I have a lot of dot phrases stolen right from the Sjogren's Foundation website of here are some tips and tricks, sips of water, all that. But then when it comes to the point where we start talking about systemic therapy, I have to be very careful. Yeah, this is not one of those like take it for 2 days and if you don't feel any better, stop. So it's like a whole different approach, and I think a more careful approach.
Yeah, and hydroxychloroquine, typical for that sort of medicine. You need to take hydroxychloroquine for many months, 6 months or so before you say it didn't really work, because it has that kind of slow onset of working very slowly. And patients have to think back, well, okay, I've been on it 6 months. It doesn't seem like it worked very well. Now you have to think back to before you started it, last Christmas, a month before you started it, are you actually better than then? It's kind of a hard thing for patients to get their head around because it works very slowly, and you don't notice suddenly, you don't notice you're better.
Yeah, that's one of the, I think one of the biggest benefits of having the EMR is patients will do PROs before they come in, and we can look back and say, 6 months ago, you said you had an hour and a half of morning stiffness, and now you say you have 30 to 40 minutes. That's that's improvement. We're on the right track kind of a thing.
We do a little sleep questionnaire. We do a little bit more, but it's kind of a research purposes. We do one of those more complicated fatigue questionnaires, but it's still pretty short. It takes people 5 minutes to fill it out.
Oh.
But it's really useful to look back at that and say, well, maybe your fatigue is a lot better.
But yeah, when we're talking about immunomodulating, or if we get into the immunosuppressives, yeah, it's a whole different conversation. And I think, at least in my experience, a less casual conversation, less cavalier, like, yeah, give it a try.
The hydroxychloroquine side effects are serious, but hydroxychloroquine is not immunosuppressive. And so you've got serious potential immunosuppressive side effects, infection complications. Yeah, you have to have a big conversation about risk and benefits with people, and they have to help decide. The big clinical trial, rituximab, there are a lot of problems with that trial, but it did have a modest effect on fatigue. But it's hard to get excited about if all it's going to give you is a modest effect on fatigue. That's all you get out of it. It costs a very large amount of money, and there's these side effects,
right?
Really serious side effects. Well, maybe it's not worth it,
especially after what we saw during the pandemic and our rituximab patients because we have a vasculitis center.
Yeah.
So that was sobering. So it's almost like a 3 or 4 tiered conversation. Like the symptomatic is look at this great smorgasbord, and you get to try, different brands, and then you get into immunomodulators, then you get into immunosuppressants, and then you get into rituximab.
Yeah.
So it's like 4 tiers of conversation. But that's the good thing about rheumatology. We get to see our patients a lot, which
that's right.
I love that.
And I think at first, patients are maybe not quite used to our approach, that they're going to be involved in their care. We want them to ask all the questions they can ask and tell us what they're worried about. Not to denigrate primary care doctors, but you're not seeing your primary care doctor where you've only got 8 minutes or something,
Exactly. God bless them. And they have to address lipids.
No, it's a very hard job.
Yeah.
It's a very hard job.
Yeah.
Especially in an academic center like you and I are at, we can have the luxury of maybe spending more time with people and really letting them be part of the decision.
In the beginning, do you find that, it takes years? I mean, we're getting better. I actually looked this up because I remember when I started in rheumatology decades ago, it took something 7 to 10 years, I think, to get a Sjogren's. And now I believe, if I looked at the right data, is it about 3 now? Yeah,
the Sjogren's Foundation of America is publishing data like that. It's maybe down to about 3 years.
Yeah.
But
so these people have still 3 years. I mean, 3 years. So of feeling worse and worse and not getting the answers. So these people have a lot of unloading and venting, and justified to do.
Yeah.
So,
well, I've gotten old enough to need a primary care doctor. I was there recently, and I'm, still doing that every visit. You have to do that review of systems thing. And, interestingly, my internist doesn't have dry mouth and dry eyes on that review of systems form. And I don't think many people have that. And so that's part of the problem. Doctors are not asking about this. Patients don't know to ask about it. Patients don't know to tell their doctor about it. Doctors are not asking about it. And so people are sort of kicking around for years without a diagnosis. I've had that.
That's such a good point. Yeah.
Yeah.
You don't ask.
I've kind of had that experience a lot, where people tell me their story and I move into that. Well, I'm going to ask you a few specific questions. Do you have any trouble with dry eyes and dry mouth? And you can almost see the light bulb go off above people's head, that they understand, yes, that they do have severe dry eyes and dry mouth. They've never told anybody. Nobody's ever asked them. And I must be onto something. We must know what's going on with them because we've asked them this question. Nobody's ever asked them.
Yeah, a lot of times they get to us after they've already, that they've almost forgotten about. They're just living with it.
Yeah.
And they're getting cavities and they don't really know. And so, well, I just must have inherited bad teeth from grandma.
Yeah,
whatever,
they don't know why.
And it's the profound fatigue and the joint pain, and someone does an ANA and the SSA is probably, and so they are already full blown by the time they're coming to see us. And
by the time they get here.
I think of myself as way more of a listener than a talker.
Yeah,
for the first few visits at least.
Yeah. And so few people, as you said, every patient's, it's sort of an individual experience. And some people may start at the neurologist. They start with the peripheral neuropathy where they're numb and tingly and have trouble walking. And the neurologist gets serology, gets blood test serologies that finds a positive ANA or a positive anti-Ro, and then they get referred to us. Or maybe you start with arthritis and people think you have rheumatoid arthritis. And eventually you get your diagnosis made of Sjogren. So it's hard to get a diagnosis made. And there's lots of these barriers, sort of this kind of patient-physician barrier, but also this logistics of getting all these things done. And even measuring the antibodies is not a trivial problem. it's not measuring your glucose or your sodium. You need to get your blood to the right place, and maybe your insurance company wants you to go to the lowest bidder, and and you don't get a very good test.
I think one of the other topics we had, and I'm curious how you do this, because you do so much research in Sjogren's, and I'm just in the trenches. But I did learn because I came into rheumatology through immunology, through an HIV clinic, and I learned very early on to not get too excited about emerging therapies with our HIV patients. If they ask, certainly tell the truth, a nice measured response or whatever. Is it same, in your experience with Sjogren's patients? Have they been sort of neglected, the redheaded stepchildren for so long that you hate to tell them there's research going on because nothing really comes out of it?
I mean, nothing's come out, in many ways, nothing's come out of it yet. A decade ago, the pharmaceutical industry seemed completely uninterested in Sjogren's, but now they are interested in it. Yeah, I try to be cautious about telling people, but there are 4 drugs moving into phase 3 FDA trials right now that have had successful phase 2 trials, but still, those drugs still have a high chance of failing and never making it to the market. There have been a couple of other drugs in the last few years that had really good phase 2 results, which are, of course, the small trials, kind of proof of principle trials. Maybe they only have a couple hundred people in them, and then you need bigger phase 3 trials. And the phase 3 trials are the ones that the companies take to the FDA to get approval with an indication for Sjogren's. But several drugs have looked good in phase 2 trials, but then failed in phase 3 trials. Maybe one of these, maybe all of them, but maybe none of these drugs that are a couple of them are already recruiting. A couple of them are going to be recruiting in early part of 2025. One of them is already approved in the United States for myasthenia gravis, so it's available. And so it looks safe. There's nice safety data for it. But I think surely one of these drugs, some number of these drugs, hopefully more than one, will make it to the market and be efficacious for Sjogren's. You can't be totally optimistic because there's been lots of failure.
It's almost like talking about the guidelines. Like in my experience, I mean, my patients aren't so interested in exactly what the guidelines are, but just knowing that somebody cares enough, a group of experts got together to make guidelines, is very reassuring. And the same thing, if they know, like you said, 10 years ago, I couldn't have told you one Sjogren's trial. And now I don't know the specifics at all, but I keep an ear out on ACR and and everything. And I can tell patients they're doing research into this. Something might be coming, and we'll let you know if any trials open up around here and stuff. So maybe it's just the knowing that people care and that somebody's looking into this. They're not just sort of on their own. It's more important than exactly what were the phase 2 results of this particular molecule.
Exactly. I've been on these guidelines committees. At the end of the day, those guidelines are expert opinion, but it's very useful for experts to get together and hash it out. Here's what you think is a reasonable approach to this disease. And that gives everybody kind of a benchmark. 50 people got together and thought we should do. And, those guidelines are not rules, but they tell you what's a reasonable approach. So, and they're going to keep coming out about different aspects of the disease. But hopefully at some point, there'll be way better data, and we'll be able to say with high certainty, this is what to do. And we know what to do because there have been really great clinical trials telling us what to do. That's not the case now, though, of course, but hopefully they're on the way.
Exactly.
Yeah.
Fingers crossed.
It'll be a big deal if one of these drugs or more than one of these drugs comes to market and is definitely effective in Sjogren's and modifies the disease. That'll be a huge, you came through it in sort of clinical immunology. I mean, I think most of these drugs they're out there because we figured out what's going wrong with the immune system in Sjogren's, and they're directly targeting some of those problems. And so that's, it's kind of a triumph of that kind of research that we're figuring out how the disease works. Still a lot to know, but it has been the impetus for bringing these drugs along that are definitely change how your immune system works. So
I come from a big, large tertiary research institute attached to a medical school. In the 30,000 foot view, we're always in favor of clinical trials. But in terms of like actually finding out who's a candidate, getting them to the right place and all that, I admit I rely heavily on our research department to pre-screen patients. And they tell me, they say, hey, you got a patient coming in later today with, for example, psoriatic arthritis, and Dr. Husney has this trial, or Sjogren's disease, and so then I just offer it to them. We have a research coordinator here who is happy to talk to you about this study if you're at all interested, and do it that way. But 100% admit that I rely very heavily on research to sort of bring the list and, the open trials to me, and then I have the conversation with patients. I don't talk to them unless there's a study that they might be a candidate for.
We have a little bit of a rarefied patient group because everybody's already consented to be in our research. It's not a clinical trial, of course, but we're probably going to join one or more of these clinical trials that is going to start recruiting in the early part of 2025. So right now I'm telling people, if you're interested, we might call you in January or the first quarter of 2025 about to see if you're eligible for this new study that we're probably going to be involved in. And we can give you the details at the time. Is it okay with you that we give you a call in the future? And almost everybody says that they're up for a call to find out about it.
Yeah, I think that's the most important point is they've been through a lot already. And so having somebody that they have a relationship with and hopefully trust, say you might get a call from somebody or this person wants to talk to you is way better than just giving their name to the coordinator and they cold call them.
Right.
I have a something that's been percolating and I think maybe for fatigue patients, so everybody in rheumatology, and specifically patients with sicca symptoms. We are lucky enough to have a wonderful clinical pharmacist in our department. And she does a lot of teaching and monitoring when patients are new starts, making sure the labs are done, and or if it's gout medication, the uric acid is a target, all that stuff. But I was thinking for more longitudinal care, because the EMRs are helpful. We're not so lost with what did your primary put you on? What did your other doctor put you, but it's still not 100%. So I was wondering, do you already do this or is it already best practice other places that to have regular visits with the pharmacist to do medication reconciliation over the counter? What role do you see for either medication reconciliation by nursing or pharmacy? In
our Sjogren's clinic, we do not really have that going as a clinical pharmacist part of our team, but that is such a important part of all this. And where we have that going, I'm on the staff of the VA here, which is right next door to us. And we have a rheumatology clinic there that has a nice embedded pharmacist. And we get exactly that in the VA clinic, this sort of pharmacy physician teamwork, pharmacy provider teamwork. And they're reviewing the drugs with us and talking to us about drug interactions that you wouldn't have otherwise recognized and really concentrating on the medicine. That is a critical part of it. And there's lots of drugs out there that make dryness worse, that, going to make you feel worse. And drugs that are really commonly prescribed drugs, even, of course, as you say, things you can get over the counter too, that people don't realize are going to make them feel worse maybe. And that seems like a really critical part of the team. And we do have it going in our VA clinics, but not at the university clinics or the OMRF clinic quite as much.
I'll bet there's a lot of pharmacists out there that would jump at the chance.
The fatigue is interesting because of course, there's drugs that impact that. But, when you survey patients, and the Sjogren's Foundation of America has done that, surveyed their membership, patients almost always rate fatigue is the worst thing. You have some interesting data about exercise and having a modest effect on fatigue, but all that's very difficult for people to do. And you need someone on the team that's going to really concentrate on that part of it. And that's all very hard to get organized. And, your insurance is only going to pay for so many physical therapy visits. You don't really need physical therapy. You need to get out there and get a little bit of modest exercise. Well, all that is very difficult. I think maybe the most important thing about is for the patient to be their own advocate. If you go to the dentist and they're ignoring your dry mouth and not really taking care of that part of your problem, or then you've got to advocate for yourself that you want them to do that, or you want to see somebody who will do that. If when's the last time their own hydroxychloroquine, and I haven't seen the eye doctor in a couple of years. They told me they called me about an appointment. They didn't call me. Well, you've got to be your own advocate and make sure you're doing what you need to do for yourself. Unfortunately, it'd be nice if the system worked for everybody perfectly, but it doesn't.
Thank you, Betsy Kirchner and Dr. Hal Scofield, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Making Progress in Sjogren's, Key Considerations for Improving Recognition, Disease Management, and the Potential of Emerging Therapies, please click the link in the show notes. And be sure to check back regularly for more episodes on important rheumatology topics.